The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast. After learning about cholelithiasis and cholecystitis, as well as simple and complex cholecystectomy in part 1 of this episode, we now move on to part 2, focused on cholangiography, bile duct exploration, and the assessment and treatment of bile duct injuries.
Dr. Khan, you were talking about intra-operative cholangiogram. Now, one of the things that I've seen in the OR too is that sometimes you inject contrast and the contrast flow is not as smooth, so you're not able to perform the procedure successfully on the first try. What are the other maneuvers or further techniques or medications or positioning that we can do to help our cholangiogram be successful?
Yeah, so I think that, there are a few things that happen, right? So either the catheter is not secure and you inject contrast and it starts to leak out around the hole. So that's a fairly common thing. So I think that can be controlled either with a clip or just using an appropriate grasper, depending on what kind of cholangiogram catheter is being used. And then the second problem sometimes is that you can't really flush. And I think the reasons for that could be that the catheter tubing is stuck again. Is pushing against the wall, and that's why nothing is flowing, or you just don't have it inside the lumen. So I think that troubleshooting with that helps too. Then sometimes, it's flowing pretty well, and then you look at the images, and all of it is going preferentially into the duodenum, and you don't see opacification above if the common hepatic duct or the intrahepatic ducts, or you don't see any opacification distally, and everything is going up. So I think you can do a few different things. So if you don't see the intrahepatic bile duct system, then it could either be that the contrast is flowing very readily into the duodenum. So sometimes putting the patient in Trendelenburg position will facilitate visualization of the intrahepatic bile ducts. So glucagon can be sometimes used too. And what glucagon does is that it relaxes the sphincter a little bit, so you can start to see flow of contrast. And the indication for that would be is that you don't see any contrast flowing into the duodenum, and you're not sure if there's something there or if it's because the sphincter is too tight. So just by relaxation, it can allow you to visualize things better.
Thank you, Dr. Khan. Now, let's see if we perform an intraoperative cholangiogram. We identify a stone in the common bile duct, and despite doing all these maneuvers, we are not able to evacuate the stone. So what are the common surgical options that you would consider in that situation?
Yep. So I think that it depends on what kind of facilities is available where you're at, also your level of expertise. So the easiest thing to do is if you see stones in the bile duct is just say, okay, we have stones in the bile duct. We're going to finish the cholecystectomy and we're going to go to the recovery, and then we're going to ask our GI colleagues to come in and do an ERCP either today or tomorrow, and that's the safest and the easiest way sometimes to approach these problems, or they can remove the stone. The downside to that is, of course, is that if you do an ERCP and they can't get in for some reason, if the patient has had a gastric bypass or if there's a lot of scarring, then you sort of have to go back and do something or transfer the patient to somebody who can, and that's okay too. The other option is if you're in the OR and you see the stones, is you try to kind of fish them out. And sometimes it's easier than others. I think you can try flushing out the cystic duct, and sometimes the stones float out. That doesn't happen very commonly. You can try passing like a small Fogarty balloon catheter and then doing a sweep of the common bile duct. It falls in the category of bile duct exploration. And sometimes with that, you can clean out the duct and you can pull out the small stones and debris through the cystic duct and then repeat a cholangiogram till it's clear. And then, the other thing is you can also use a choledocoscope. It requires a little bit of experience, but it's a pretty nice way of getting direct visualization. You introduce the scope through the cystic duct, and it's easier if the ducts are big, and then you can pass it down and see if you can see a stone. If you see a stone, or if the stone is impacted, then they often come with a basket that you can use to grasp the stone and remove it. And sometimes, if the stone really is impacted, you can even use lithotripsy with that to break it down and try to remove the fragments. In reality, how often are these done? Not very commonly. I think just because the GI doctors are so good with doing ERCPs that most of the time we do not need to do these. But these are always good to know because sometimes you end up with that. If all else fails, you can always do an open bile duct exploration or even a biliary bypass if the need may be, depending on how bad it is. But I think that's a little beyond the scope of this chapter.
The open major liver resections and the transplant procedures that Dr. Khan performs are an amazing opportunity. So if as a resident or as a medical student you're in those cases, it's a great opportunity to just delineate the anatomy of the gallbladder in an open manner. And as Dr. Khan mentioned, that since the practice is moving more towards laparoscopic cholecystectomy and robotic cholecystectomy, you can use those procedures to improve your knowledge and techniques on how to perform an open cholecystectomy. One of the other things that I would like to mention at this case was at this point is something called a calculus cholecystitis, which so as surgical residents we see commonly in ICU patients who have been NPO for a long time or are on TPN, and they can develop cholecystitis without presence of any gallstones. In that case, there is utility for IV antibiotics, IV fluid resuscitation, and also a percutaneous cholecystostomy tube that can be performed to facilitate adequate gallbladder drainage. Dr. Khan, taking this conversation further now, so during cholecystectomy, one of the most dreaded complications is a bile duct injury. How do the patient usually present with bile duct injury? Obviously, it can be caught intraoperatively, but if it is not caught intraoperatively, how do the patient usually present with bile duct injury?
Yeah, so I mean, the whole goal of doing safe cholecystectomy is to avoid a bile duct injury because that can have pretty significant implications and life-altering outcomes for the patients. And that's why I think it's very important to, again, refer to the Safe Cholecystectomy Initiative and the critical of safety that's present in some of the attachments to this chapter. So, but sometimes, despite the best of our efforts, things are really inflamed or anatomy is aberrant and complications do happen. So, bile duct injury is very dreaded. Thankfully, it's very rare. It's more common in patients who are getting the operation for acute cholecystitis rather than for biliary colic. It's important to note that only about 25% of them are picked up intraoperatively, either via instead of finding one duct, you realize that you've transected two ducts, or you do a cholangiogram and that confirms spillage of contrast through the duct, or that you're in the common hepatic duct or the common bile duct. But majority of them are not picked up. The patients are closed and they go home, as most patients have elective same day or overnight stay surgery. And then these patients present a few days later. Typically it's 5 to 7 days, depending on what kind of injury they've had. And they can have a whole range of symptoms. Usually it's worsening pain. They're feeling worse instead of feeling better. You can have jaundice or dark urine, especially if the bile duct is ligated or there's a big bile duct collection. Patients can often present with fever, and anybody who presents after a cholecystectomy with those symptoms and basically feeling worse instead of feeling better, one must be very wary of a possible bile duct injury and do a thorough examination and testing of the patient to look for that.
Now, talking about the workup we can do to help with our diagnosis, we will obtain a CBC, a liver function test with direct bilirubin. We also have several imaging modalities on offer, like a CT scan or MRI, or an MRCP with angiography, HIDA scan, or an ERCP or percutaneous transhepatic cholangiogram. Dr. Khan, can you briefly go over what your approach will be in diagnosing a patient with suspected bile duct injury?
I think you brought up several very important points. I think that the index of suspicion is how most of us start off with. So I think that on the blood work, and somebody who has a potential bile duct injury, you could expect to see elevated white count and some liver test abnormality, depending on what the injury is. But it's also important to know that the liver test can be completely normal in somebody with a complete transection of the bile duct, because if the bile is freely flowing, then the duct is not obstructed. So normal liver tests do not necessarily mean that there is no bile duct injury. Imaging studies, most of the patients end up start with either a CAT scan or an ultrasound. I think a CAT scan, if you're worried about bile duct injury, potentially a CAT scan is often a good first test, with contrast if possible. And things that we're looking for is any signs of dilated intrahepatic bile ducts or any big fluid collections in the area. And I think, like Dr. Panni mentioned, that it's also important to try to look at the vessels, because the right hepatic artery especially can often be injured. And it's very important to know that before, not just for reasons that will help with planning the reconstructive operation, but also from a medical legal perspective as well, because you got to document the extent of the injury going forward, especially if you're not the one who did the surgery and you're now getting involved and doing the reconstruction. I think a lot of the patients get an MRI and MRCP once there is suspicion for bile duct injury, because that's a pretty good relatively non-invasive way of looking at the bile ducts. It often will guide us regarding the level of the injury and also the extent of it. And you can get some information about the vascular structures as well. ERCP is another test that's commonly done. I think that, if there is a complete transection or a defect in the side of the bile duct, then it can be of some utility. But you must be wary is that if the common bile duct or common hepatic duct was completely clipped and then divided, then the ERCP may not show anything. It's just going to go up until it reaches the clips, and then there's going to be no extravasation and no visualization of intrahepatic trees. One should also look at the number of clips. I think there is some correlation with the number of clips with bile duct injury, so I think that also gives a little bit of a clue. And you can do HIDA and other tests, but I think that they're a little bit less sensitive. And also now in the modern days, with all the other tests being so good, there's a lesser yield of it for getting it in patients with bile duct injury.
Thank you, Dr. Khan. So you brought up that 25% of the bile duct injuries can be identified intraoperatively. So if that happens, how would you manage the patient?
Yeah, so that's a very good question too. So I think that if you're doing the operation and your suspicion is high for a bile duct injury, do a cholangiogram, which confirms it, or if you realize that you are in the bile duct, then I think there's several ways to go. Again, it depends on the experience of the surgeon. I think if the surgeons are experienced, they can do a repair, and traditionally, if there is less than 50% circumference injury to the bile duct and it's clean, then it can be sutured over a T-tube. Sometimes if the duct is really large, it can be primarily sutured as well, but there is a risk for leakage in that, and one must make sure that the edges of the bile duct are clean. With thermal damage, you could have a higher chance of a leak from that. If the bile duct is completely transected, or then and the person is experienced, then in the OR, the Roux-en-Y hepatico-jejunostomy can be done as a definitive intervention, but that is not necessarily available everywhere. If you do have partners who do hepatobiliary surgery, then getting them involved at this stage is probably the best thing, and they can do a definitive repair. It's important, again, to make sure that there is no damage to the hepatic artery, because that can compromise the integrity of the repair and can cause complications. If there is vascular injury, then we typically would not do anything at that time, just leave some drains and come back and fight another day once the ischemic extent has been allowed to demarcate, and that typically takes a few weeks. But let's say that, if you don't have the expertise in the hospital and you're not comfortable and you notice that there is a bile duct injury, what we would, and we get that phone call a fair bit, from outside community surgeons where they're in the OR and they're worried about a bile duct injury. And what we tell them is as long as there's no bleeding, is just to leave a drain in and to close the patient. If they're laparoscopic, to stay laparoscopic, just leave a drain in and close the patient, and then just transfer the patient over, and then we can take it from there. If they are open, sometimes tagging the bile duct with a little piece of suture can help identify it, but that's not a necessary requirement. I think the big things are just draining and closing the patient and just sending them over.
Thank you, Dr. Khan.
Stay tuned for part 3 of this episode to learn more about post-cholecystectomy bile leaks and the assessment and treatment of choledicholithiasis and acute cholangitis. We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.